Hi, we're here with Robert Uzzo, extraordinaire, not only a great surgeon, but also he defined several things that we're gonna mention, we're gonna talk now. We're here at Jackson Hole Seminars. Rob, thank you so much for being here. I mean, this is really great. And the way that you interact with the audience is just awesome.
Thank you.
So there are a couple of things that I like to touch on. The first is the professional things and some, things that you wrote extensively about kidney cancer. And then I like to know a little bit about Rob.
Great.
And so the first thing is nephrometry. Boy, that was such a great idea. How did you have that idea?
Well, first let me say thank you, Fernando. You've always been a good friend and
Yeah.
a great colleague, so thank you. This is one of the great meetings I've been to, and to have me back twice is a special treat, so thanks. All right, so listen, I once heard some advice from someone. They said, if you see or hear a good idea, don't be afraid to adapt it and steal it. And so when I was a resident, I was thinking about, going to the general surgery conferences, and the liver surgeons are really good at this. They were talking about the hepatic segmental anatomy. And somebody would get up and they'd say, we have a lesion in segment 7 of the liver. And everybody would automatically know, that's hard, that's easy, where it is, what does it mean? The implications were communicated in a very sort of clean and discreet way. So as I became a fellow, I spent some time thinking about this. And I thought about the segmental anatomy of the kidney, and I came up with very many different iterations of how can I communicate complexity, how can I communicate sort of risk, uncertainty, and decision-making, use it as a decision-making tool. And I thought, I came up with a bunch of different ways based upon the arterial anatomy, based upon the collecting system anatomy. None of them seemed to work. And so what I thought is, along the way, why don't I just sort of come up with a scoring system? Other places have used scoring systems. It's just an objective measure to classify, complex decision making. And then I thought, well, what I really need to do is I need to sort of come up with a catchy name, because otherwise no one's going to remember it. So, as an attending, a young attending, I had a fellow, and I said, look, I've got this idea. Here's what the sort of key characteristics are. Let's brand this somehow. And he came up with the acronym RENAL, R-E-N-A-L, and I came up with the name nephrometry. And that person was Alex Kudikoff, who came up with the RENAL acronym. And so, we put that together and we published it. Nephrometry really is just geometry of the kidney. And suddenly it took off. I'm not thinking that it's changed the world, but it clearly has allowed people to sort of talk a little bit more meaningful about how they make decisions. Dr. Novak used to say to me, somebody might think this is a complicated kidney tumor, but we know it's not. And so I was just looking for a way to sort of communicate that simply, and that's where it came from.
Oh, that's because nobody, when you read your wonderful papers, you don't have any idea how that came to really develop and now see what everybody uses,
Yeah.
And at the AUA this year, you talk, or last year, Dr. Caboose and you had such a great, rich plenary session, and there was one thing that really I paid attention. You were talking about cutting and probably some posterior kidney cancers that will come back. That the margins were negative, and I do a lot of ablation because the apoptotic reaction occurs, and I'm using that knowledge to keep doing what I'm doing, although I really enjoy doing laparoscopic partials or even open nephrectomies, but try to bring the value-based outcome of the patient's survival, all this together. What do you think the future? I mean, if you understand, we're surgeons, but instead of cutting, probably putting needles, ablating, whatever technology, and not performing ischemia reperfusion injuries to the kidneys, and not knowing the physiology and very well the reperfusion pathophysiology in the kidney. Now, I don't know what your thoughts are.
Well, I've been very lucky to be trained by very good people. I've had very good, mentors in my life. I've got a picture over actually I have 3 pictures over my desk, and they're 8 by 10 pictures. One is of my father. He told me how to be a good man. The second is of Dr. Vaughn. He showed me how to be a good urologist. And the third is of Dr. Novak. He taught me how to be a good surgeon. And I ask myself sort of, what kind of strategies these men had in their lives that I could develop. And so I've tried to develop strategy. And the strategy that you're alluding to is that I really do consider myself not a surgeon so much as a risk manager. My job is to manage the patient's risk because the future is uncertain for all of us. And so if I think of a person who comes to see me with a renal mass, and they've got all sorts of other comorbidities, they've got other sort of competing risks, they've got other sort of hospital risks and physician risks and biological risks, how do I present to them a risk mitigation strategy that allows them to sort of face the uncertainty of what this means in the context of their lives and their other medical problems today? And so I've got, I've had many talks about this, and I've had sort of, thought about sort of constructs and other sort of ways to communicate those risks. Clearly I'm not the only person, but when it comes to localized kidney cancer, this is what gave me the idea of this sort of monitoring the small renal mass. Now, when I left the Cleveland Clinic as a fellow, I realized that I wasn't going to do more partial nephrectomies than Dr. Novak in a decade, and I wasn't going to do more laparoscopic anything than Dr. Gill. These are fantastic mentors and fantastic individuals and surgeons, but I had to find something that I could sort of, grab onto and resonate and add. I mean, my goal is to move the ball down the field, right? So how do I do that? Well, the idea of observing a small renal mass. Why? Because in the sort of calculation of risk for an individual patient, the small renal mass, you can't over quantify that risk if the person's elderly, comorbid, has poor renal function, etc. So then that sort of carries to the questions you were asking. At what point does the risk justify ablation? At what point does the risk justify sort of percutaneous versus laparoscopic ablation or excision? And so what we all have to do as physicians is we've got to sort of come up with strategies to understand, to communicate, and ultimately to mitigate the risk. And there's not like a single right answer, right? But you have to sort of, put that in the context of a little bit of, I think, understanding also what the motivations are. So there's a motivation for the patient perhaps to sort of get something done, and or other motivations. There's also motivations for the physician, right? We're all evaluated by our clinical decision making and our clinical, our productivity. So I'd say that, if you're asking me the question about how these complex decisions are making, my strategy is be a risk manager, try to sort of calculate and communicate uncertainty, and then ultimately look in the mirror and try to be humble about what the motivations are and the incentives are, on your end of the equation, and try to extract those, a little bit when you're making those decisions.
I wouldn't expect a different answer. If you run a very busy practice, you're leader of a group of brilliant surgeons and researchers. So when we talk about burnout, what do you do to relax?
Well, I think burnout is real. In your generation, and I guess I could call it a generation. I don't feel old enough to be part of a generation, but it used to be that, we would sort of, that was a sign of weakness. You can't admit that, somehow it's just too much. But there have been points in my life where it has been too much. I've been very fortunate to be supported by a wonderful wife and wonderful children, and they have been, more than, accommodating to sort of the demands of all the things I've tried to either do for my patients or do for my profession. So what do? I read a lot, and I don't always read. Unfortunately, I don't always read anymore sort of the sort of urology specific journals. I do a lot of reviewing for them. I flip through the table of contents and I look at them, but really what I'm looking for is abilities to find lessons outside our specialty and outside our profession, because so many other professions have to deal with many of the same elements. How do you communicate with patients? How do you operationalize complex processes? How do you sort of, contend with uncertainty and the things that we have to do? Really, I mean, you could talk about sort of, the uniqueness of our specialty, but there's also a lot of things that are they're commonalities. So, some doctors, find it a little bit sort of off-putting when someone, tells them how they have to practice, and they step back and they say, whoa, I've got people's lives in my hands. Every time I get in an airplane, as far as I know, the pilot's got their lives in my life in their hands too. And it's just as visceral, and it's just as real, and it's just as, risky. And, I try to learn from people outside. So I read a lot. Last vacation, I'll just give you an example. I read Liar's Poker. That's a really great book about sort of Wall Street, and I read When Genius Fails. I read Sapiens, which I thought was a fantastic book. I read Where We Are and Who We Are and Where We've Come From, which is an evolutionary biology book. I really try to sort of be as eclectic and sort of in my exposure to other ways of thinking as I can be. So I like that. I play squash with my son. I took up squash with my son about 7 or 8 years ago. I enjoy that immensely. I'm not that good, but it burns some calories. I try to run, 3 or 4 times a week. And beyond that, I enjoy going to the movies, and I just want to be with my family.
Yeah. What kind of movies then?
Usually it's the indies. I really do like the indies, yeah. So,
Roma.
Roma, that type of stuff. Yeah, I mean, some of the offbeat stuff, sometimes, it's just another form of communication, another form of expression, right? When I was, one of the first papers I ever wrote, Fernando, was an art and architecture paper. I was very lucky to spend, 6 months in Florence, crawling around cloisters and, sort of measuring ratios and golden means and stuff. And I really sort of, I can't paint, I can't draw, but I can appreciate. And I appreciate good music. I appreciate going. We have a family subscription to the Philadelphia Orchestra, and we do those types of things. So that's
what
just
kind
something.
of music then? Other
than classic music, well, it's got to be classic rock. Yeah. Classic rock, of course. Yeah.
We're talking about Led Zeppelin.
That's right.
All the other from Eric Clapton.
Eric Clapton's terrific. Yeah, I mean, right now. So if you ask me, sort of so back in the 70s and 80s, like I'd listen to most anything, because I like the sort of the guitar riffs and frankly I also like the sort of singer-songwriter. So a guy like John Mayer, for example, I really like John Mayer. He's a fantastic guitar player. He's a fantastic communicator. So that's the kind of stuff I look for. I don't like it's obviously situational, right? But I generally don't like angry music. There's some angry music out there. I'm not,
And Dr. Cavusi, one of my mentors, and he plays the bass.
He does. He's good.
And we were in Rome, one of the meetings, and Pierluigi Bovi, Italian great friend, a brother, put together a band. I play and sing, and we had a lot of fun, and we continue to have a lot of fun when we get together. But those are the things that are important. And then I wonder where is home for you? Where did you grow up? Just to have an idea.
The short story is I grew up in New York, right? I'm a Long Islander, a New Yorker. The longer story is my dad is first generation Italian, my mom's second generation Italian. And so I spent a lot of time in Brooklyn and Queens and, Manhattan. And, so I feel like New York is basically where I spent most of my life.
That's awesome. I like to thank for your time and to invest on this scientific kind of social group that we have here, and we're gonna really count on you to continue the legacy of Ralph Hopkins. Thank you so much, Rob.
I never met him, but I assure you that I'd really enjoy having him done so. Yes. Yeah, this is honestly, you've got to be commended too for carrying on his legacy, because it's a fantastic meeting. There's very few formats like this, where the lectures are punctual, they're concise, they're focused, and then you have a chance to sort of put it out all on stage and sort of lean on each other, right?
Yeah,
it's great.
It is.
Congratulations.
Thank you so much.
All right.